So, hi everyone, my name is Sinead. Today I'm going to be talking about sports therapy and working with clients, going from early stage rehabilitation to late stage. So probably more relevant to one-to-one clients, even working with community groups. So hopefully you can get some kind of interesting ideas out of this, maybe for working with different clients, depending on kind of what stage they're at. So with rehabilitation, I would get a lot of clients saying to me, particularly after hip replacements, knee replacements, that they feel like they didn't get adequate rehabilitation, and they feel like now it hasn't been, say the joint hasn't been restored to full function, or there's been like a buildup of scar tissue, and that's kind of limiting the range. So one of the consequences of inadequate rehabilitation would be predisposition of injury to other areas, and then of course, the lack of return to full function within that joint. So with rehab, especially in the early stages, we're trying to reduce the inflammation present after injury or after surgery, and we're trying to reduce pain, of course. And then we're gradually starting to try to restore that range of motion. So back to the range of motion that they had previously, or as much as we can, restore function, strength, of course, and then start to restore proprioception and neuromuscular control. So those things that are really going to impact our balance and how we kind of react to unstable surfaces, where injuries and damage to muscle tissue can actually negatively affect our proprioceptive abilities. I'll talk more about that though later on in the slides. So this is just a little picture of the pain spasm pain cycle. I just wanted to include this because it's quite interesting the way, so we experience an injury or we have surgery or there's damage to muscle tissue. And of course we experience pain, but then we start to guard that area and trying to prevent further injury. But in turn, we reduce blood flow and we almost stop the healing process. So we stop the kind of circulation of oxygen and all those good healing materials. And we prevent the kind of flushing out of inflammatory cells. And then we experience more muscle tension, inflammation, again, reduced blood flow, therefore reduced movement because we're experiencing more pain. There's a lot of inflammatory cells in the area, and so on and so forth. The cycle continues. So with rehab, with what we're doing with movement with clients who have injuries or after surgery, we're trying to kind of come in at that cycle, intervene, start to get some movement into the area and allow that healing process to occur, and to also kind of help with the laying down of collagen and tissue. So with the buildup of scar tissue, especially after an injury, it's important to get movement into the area so that we help to kind of more to correctly realign those fibers, basically. So just a little bit on program design, particularly relevant for our one-to-one clients. So when I meet a client or when I'm talking to a client, at first, I want to explore their main concern, obviously, or what are their main concerns. And then, of course, looking at making a specific program for them. So what are their functional requirements? What do they need to do currently that maybe they're struggling with, whether that be getting up out of their chair and answering the door. So trying to make sure I create a program that's specific for them. And then we can look at things like goal setting. So in the short term, that's obviously going to be things like reducing swelling, reducing pain, and starting to increase range. So even just after one session, just after a little bit of movement, we'll start to experience an increase, or maybe a small increase in range, but even certain movements like moving their head can feel a little bit better. And we kind of have that sense of well-being after the session then, and they want to come back. And then looking at long term, it might be things like improving their walking gait or increasing their strength. And again, this is going to very much depend on the client, but it's great to have something measurable. So particularly they want to get stronger, or they want to feel like they're getting stronger. Maybe they want to be able to do, they struggle with sit to stands. They want to be able to do, say, 5 sit to stands in 2 months. And maybe we can assess if that's realistic or achievable for them and decide to measure things in that way. If we want, just a good idea, it can be a great way if it's possible with the client. And it can be something really small as well. Just to have small little things that we can measure can be great in terms of motivation and making them want to continue with the program. And then, of course, a big part is monitoring how your client is responding to the exercises. So I'll ask the client just to see how they feel 24 hours after our session and maybe 48 hours after. So if there's a bit of pain, maybe a bit of discomfort or muscle soreness even, and say within 24 hours after a session, that's okay. So long as that's mild, fine. If that continues, that can be a good indicator to me that maybe I need to reduce the intensity at which we're working. So that could mean reducing our sets or reducing reps. And if there's no pain, no muscle soreness, that can also be a good indicator that maybe we can start to progress things and make things a little bit more challenging. So just starting with the more kind of early days in rehabilitation. So in this stage, we're going to be focusing mostly on decreasing pain and inflammation and starting to restore range. So there'll be a big focus on isometric contractions. Isometric contractions are basically a muscle contraction is occurring without motion actually happening in the joint. So we're producing a force, but there's actually no motion happening in the joint. So say, for example, if we were doing an isometric contraction with a bicep curl, maybe we have a table here and we're trying to push up against it for about 6 seconds, relax. And say if we're looking at a client who has just had a knee replacement, one of the exercises they'll be told to do is they'll be lying in bed. So let's just pretend this is bed. They'll be told to push the back of their knee down into the bed. So if you try to do that, you'll feel your quads starting to work straight away. But there's no real motion going across the joint here. And it's just a safe way of creating blood flow and starting to work on building strength without too much kind of load going through the joint. There's ways we can modify this, of course. So maybe if that's a bit painful, instead of saying doing a really strong contraction at like 100% of what they can do, maybe we ask them to do like 60%. And we can build it up that way. We can also build it up, say, start with 6-second contractions and maybe move on to 10, and maybe doing 3 sets. And then just in terms of, say, starting to work on our core, which is going to be a big part of balance proprioception. For the early stages, maybe we just start to work with bracing. So what I mean by that, take a breath in, breathe out. We push the lower back against the back of the chair. 3, 2, 1. Relax and go for reps here. So breathe in. And if you push your back against the back of the chair, breathe out. You'll feel those muscles starting to work here. So again, just another safe kind of isometric contraction, a way to start to get movement safely and start to build strength. So we'll also be looking at range of motion exercises, non-weight bearing to start, so just no weights going through the joints. That could look like starting to get some arm swings in. I find a really good way, especially to get movement into the joint and to start to restore range. And this can be great in a warm-up or for people who get pain in their joints or who have arthritis, to start to get rotations happening within a joint. We can take the elbow in, do it into the side. So this is just a nice gentle way to get some rotation into the shoulder joint. And just opening out like so. If we want to make it harder, we can come here, trying to keep elbow in line with shoulder. And we can add resistance to these exercises as well. So I could have a band in my hand and it could be tied to something here, but that would be in later stages. But these can just be really nice ways to start to get some rotation, some movement into the joints. Another one that I find good for the hips. So if anyone does their 90-90 exercises on the floor for their rotation of the hip joint, this is kind of like a nice seated equivalent. So feet a bit wider. We keep the knee where it is, so we don't let the knee come up off the chair. We're not bringing the knee in or out. This bone stays facing this way, and we're just sliding the foot in and bringing it back down to the floor. So this is just a really nice, gentle way to start to get those deep kind of hip rotators working without too much force. We're not standing, but you'll actually feel your hip muscles working. If you put your hand there, you'll feel that. And I just find it's a nice way sometimes to start to get a client moving and they get to feel that movement happening as well. And then if we're going for the opposite of that, so that's us kind of externally rotating. If we go and bring the feet in a bit closer, keeping the knees where they are, and we move this way. the foot out to the side, keeping that bone facing this way. You'll feel that working as well. And that's just us kind of internally rotating the femur there. So just really gentle ways to get movement and to start to get those kind of deep muscles that work to help us rotate our joints in a kind of safe, partial weight bearing way. So then another thing I'd be looking at here is just asking them throughout any pain or discomfort while you're doing this. If so, where do you feel it? Some pain is okay, but again, mild, we want to monitor, especially 24 hours after, 48 hours after, to tell us whether or not we need to decrease sets and reps, or whether or not maybe we can start to progress and make things a little bit more challenging. Okay, so then moving on to intermediate rehab. So here the client started to build up their range of motion, they're a bit stronger. Again, we can take ideas from this, snip and pull. It completely depends on the client. It's not necessarily going to work like, clockwork stages. But in this stage, we're looking at more concentric contractions. So what's happening here, the muscle is shortening and a motion is occurring basically throughout the joint. So the fibers are shortening to produce force. We're starting to look at weight bearing work here. So that could be standing, even using crutches to work on gait. So we might be doing kind of work with terror bands, work with our resistance bands. One that I find particularly good, a lot of clients, especially ones who, kind of have hip issues or knee issues or some weakness there, most people do. You'll see them do it when they go to stand, their knees come in. I see people do that all the time. That could be because of several reasons, but a good bet is that you probably have weak muscles here, and probably our hip muscles are quite weak, and our abductors generally will be quite weak. And we want to make this a strong, solid position, especially getting up to stand. So one that I like to work on with people, on my band, and I just get them to tie it around the legs twice, make it safe. And I'll start to get them working here. So the minute you have the band on, I get them to put a little bit of resistance through it. So they open their legs slightly, and then straight away those muscles have to work just to keep the band where it is. So they're having to stabilize throughout this whole exercise. If I'm starting on this leg, so if I'm starting the exercise on this leg, this one now has to work to keep the band where it is to stop the knee from coming in. So if I'm doing my abductor exercises here, I'll lift the foot slightly off the ground, come out, and you'll feel that straight away, in, back down. So this would be an example of some concentric work that we could do with someone. Particularly great for if we're trying to work towards our sit to stand or make our sit to stand that bit stronger. This can be a great exercise for that. We can also, if our client is starting to progress, work with their sit to stands with the band. Obviously, this is going to make it a lot more challenging, but just a great way of starting to get those muscles to work a bit harder to stabilize. So this leg is really having to keep the band here while this leg is working. So a great way to get those muscles seriously working while we're doing this. Then, of course, we can start to move on to more standing work. We can do similar things, but in this stage, it's important to just look out for, say, a client is coming back from an injury or some kind of surgery. You might start to see compensatory movements for a lack of range or a lack of strength. So with abductors, you'll often see this, where they're kind of using momentum and leaning to the side. And they're doing something, but they're not necessarily getting the full benefit of the exercise. So just looking out for compensatory movements like that. So maybe cueing, okay, trying to stay upright, trying to use your strength. So hold for a second at the top, then come back down. So we're trying to build strength here as opposed to, say, those range of motion exercises where we're kind of, swinging the leg out to the side. So just looking out for little compensatory movements like that, particularly after surgery or an injury, where there probably is some type of weakness or lack of function. And then we're going to start to look at more dynamic core exercises. But I'll talk about that towards the end. Okay, and then we're moving on to our late stage rehab. So late stage rehab, a little bit different. We've built up quite a good deal of strength. And now maybe we can start to incorporate eccentric training. So eccentric training is a little bit different. Quite interesting research in this area in older adults. In case anyone wants to take a look, I've added a reference. Eccentric training, what's happening is the muscle is lengthening out under load. So say I have a weight in my hand, I'm slowly lowering the weight, the muscle's lengthening under load. So this can be a really, really effective form of strength training. Really high force production at a relatively low energy cost. Also, researchers have shown that in older adults, eccentric strength is actually better preserved than concentric. So just an interesting line to possibly look at, especially with people, say, just starting out in strength training or who find it quite difficult, a kind of interesting avenue there. But also a great way to start to improve strength going downstairs. So most falls happen on stairs when someone's going downstairs. So if you're going to fall on the stairs as an older adult, you'll probably fall going down the stairs. And one of the reasons, I suppose, for this is when you're walking downstairs, quads are eccentrically loaded along with the calves, the Achilles. And the hypothesis would be that if we build up that eccentric strength, maybe we can start to work towards, reducing the likelihood of falling down the stairs. So just one little example of that, say we are doing sit to stand. We do our sit to stand, we go 1, 2, 3, 4, and I'm sure we all do, a lot of us will use this just to build up control and strength in this way. But here we're basically performing an eccentric contraction. We're eccentric contraction. And we can work with weights as well. So again, just another way to start to make the program a little bit more challenging and elicit kind of more sort of strength changes, hopefully. And just a little note, obviously older adults are more prone to muscle damage, and eccentric contractions do elicit more muscle damage most of the time than, say, concentric contractions. So a little bit more advanced. We're nearly there. So now just looking quickly at proprioception. So proprioception is basically our awareness of ourselves in space. We have proprioceptors throughout our body that allow this to happen. So we have proprioceptors in our skin, our tendons, our muscles. We use our vision and our hearing to help us with proprioception. So it basically is just our awareness of ourselves, of our joints in space. And a big part of developing proprioception will be balance and coordination. So when we injure an area or experience damage, one of the hypotheses is that this leads to proprioceptive deficits, because of course there will be a damage to proprioceptors, along with aging. Obviously we see loss of vision, loss of hearing. So all of these things are going to affect proprioception. So big parts of starting to try to keep or improve proprioception is, of course, balance and coordination. So if we're in the early stages of rehab, balance might look like the stuff we were doing with, say, the soft balls, where we were balancing like so. We're not really putting much load through the joint, but we're starting to work on a little bit of balance. As we progress on, it might look like our single leg balance, static single leg balance. So we're just holding still, not moving. To make it more complicated, we might add some movement, so some perturbations. Making a little bit harder. Okay, and then we're starting to look at core, of course, as well, which I did mention, but core, and there's more research coming out on this. Huge part of balance. So our core muscles is kind of our stabilizer, what stabilizes us and allows mobility of our other joints. And there's more and more research coming out to kind of show that trunk strength is associated with better mobility and better balance in older adults. So with our core, say for example, like what I was talking about in the early stages, we might just be working with that bracing, making sure that they're breathing. That's a big part. So taking a breath in, pushing the back into the back of the chair, breathing out. And it might just look like this, trying to do contractions like that. 3, 2, 1, relax. So on and so forth. With the, we do sets of this, say we do like 10 repetitions, take a rest, take a little rest in between. And then as we move on to kind of more complicated stuff, we might start to look at our rotations, using those muscles to rotate us, lateral leans. And then if we want to make that more complicated or add a bit of instability just to make it a bit more applicable to real life settings, we might get a wobble cushion. This obviously isn't a wobble cushion, but if you have one, just to make things, that surface a little bit more unstable, make things a bit harder, and maybe we start to do our core exercises from here. It's a little bit trickier. And there's endless ways in which we can make core exercises harder. So if we're doing our rotations, maybe we start to bring the legs out. That's going to make it harder. So just going on and progressing, starting to add a bit more stability, starting to make the training kind of more applicable to everyday life. So just to finish up, in terms of client education and motivation, I find it can be great to sort of explain to a client why they're doing the exercise that they're doing. They often seem to really appreciate that. I also find it helps with motivation for why they're doing the exercise. So say, for example, with the abductors, I might just simply explain to them why we're doing these ones. So I might say, okay, if these muscles are weak, it means that our pelvis is more likely to become kind of unbalanced. So when we're walking, you start to see this kind of tilt. If you're balancing on one leg, you might see a tilt out to the side. And generally, that's a good indicator that these muscles are weak. So when we're doing this, we're trying to straighten those muscles and therefore improve our gait, improve our balance when we're walking so that we're not experiencing this like tilting so much of the pelvis out to the side. And then obviously offering simple explanations and then encouragement. So when they're going through their program, instead of counting their reps, like 1, 2, 3, instead of that, talking to them while they're doing the exercise, where they feel it, offering cues maybe specific to the exercise. So say like, okay, try to keep upright. Simple cues like, okay, breathe, take a breath, make sure you keep breathing, belly to spine, so on and so forth. So instead of, just sitting there counting reps, offering kind of more interesting encouragement and maybe different kind of cues and explanations. And that's me. So if anyone has any questions, go for it.
Ou si vous avez des questions en français, je peux traduire au besoin.
No questions, thanks. Pretty good.
All right then. Thank you very much. Well, I don't know if French people have questions about the content. Si en français vous avez des questions sur le contenu de la séance, sur des exercices, si tout est OK. Sinead, can you send it to me, the PowerPoint?
Yeah, no problem.
Perfect, thanks. I will give it to you with the replay. Et je vous enverrai la présentation avec le lien pour le replay si vous souhaitez visionner de nouveau l'échange. Well, if it's everything okay for you, well, I wish you a really good day and a good summer, and see you next month for the next exchange. Bye, everyone.
Thank you very much.
Bye.
Sinead, that was really cool.
Bye.
Thank you.
Thanks, guys.